I'm speaking today, really giving a bit of background on the Clinical Advisory Committee's activities and a bit of a clinician perspective. This isn't the first time that I've spoken at the conference. I spoke 4 years ago, and I remember being absolutely petrified. I was quite new to the game at that stage, and was sandwiched between Shane Solomon and Stephen Duckett in the first morning plenary, and found that a little bit intimidating. I was deputising for Ian Goff, who's recently retired as chair of the IHPA's Clinical Advisory Committee, and I think the Clinical Advisory Committee would thank him for all his hard work. So on that occasion, it was a new game, and I didn't really have a huge perspective on the intricacies of ABF, and so I took a sort of comic relief type role and threw out things like I thought Weiss was something to do with making ice cream and such terms, but I'm not going to get away with that, I suspect, today. So I will move on and give you a little outline of what we're going to talk about. I'm going to talk a bit about the Clinical Advisory Committee itself, and then some of the things we do as part of our normal business. A little bit of background on some of the input we've had into the teaching, training and research question, and as the theme of the meeting has really been in the safety and quality area, a little bit of perspective on our role in respect of the Joint Working Party. We also do a little bit of horizon scanning, or what I've described as horizon scanning. That's sort of looking at things that are coming over the horizon that may or may not be picked up at a level that is going to need adjustment with respect to the nationally efficient price. And then some of the unintended consequences that can occur in this sort of area, and unintended consequences, I suppose, is in some respects a synonym for complications. I'll finish based on the same theme as Robert Hercus did yesterday, with a little case vignette, because after all, as a clinician, that's the thing that I know best, as opposed to the details of ABF. The Clinical Advisory Committee itself was formed as part of the National Health Reform Agenda and the Act in 2011, and really, like a lot of the things in the National Health Reform Agenda, is about putting clinicians in places that they can advise and give their perspective effectively. Initially, it was in my opinion, a sort of physician or clinician in the street type approach. As clinicians, we constituted a sounding board, but as time has gone on, it's become quite clear to me that I'm surrounded on the committee by people who are absolute experts in their areas and bring a great deal of high-level knowledge, not just with respect to clinical practice, but with respect to funding, etc., to the agenda. It's a multidisciplinary group with nursing, allied health, and doctors on the group, and I will use the sort of term clinician to cover over all groups of people in clinical practice. We do inform issues around the nationally efficient price, and we do have a role in determining what may or may not be unintended consequences of the efficient price, and where, in fact, pricing may drive changes in model of care that not necessarily the direction that we want to go. So we do have a role that not only reviews the data, but also reviews the consequences of the way in which we count and the way in which we price things on clinical practice. So, and things that, examples of those sort of things that we've achieved include work in making sure that multidisciplinary meetings are effectively covered off in the pricing structure, and and interactions that sometimes occur both with and without the patient. Our other areas of contribution are to make sure that when working groups, subcommittees, and the IHPA needs to go to clinical groups, they've got sound advice and who those appropriate stakeholders are. So, for instance, when one wants to get advice on things like mental health, then one obviously wants to be linked up with the appropriate industry areas, the colleges, and the professional groups in allied health, psychology, etc., that interact. So, as a clinical advisory group, we provide a resource to the IHPA in connecting them to areas of clinical expertise to speak and have a role. It's also important that we, when reviewing the information that comes back from the jurisdictions, that where there are apparent discrepancies, we have the Clinical Advisory Committee members can sort of assist in digging down and looking at the way in which variations in practice may result in significant differences in data, even though overall the outcome or the process is actually very similar, so explaining where things don't apparently seem to be as they should. I'm going to go in a bit more detail on some of the other areas. Obviously, there's some valuable work being done both by the IHPA and with the Clinical Advisory Group having a role outside the funding agenda, and we've heard quite a lot about the new mental health classification, but the work in teaching, training and research is also significantly important, and the linking of quality and safety to a pricing framework is an important piece of work. But the new, the classifications, we're all familiar with the ARDIGs, the AN-SNAPs, and other areas, the use of Tier 2 in outpatient areas, and the fact that that's a fairly blunt instrument, and the Clinical Advisory Group, I suspect, has a role to play in evolving that process effectively. It also clearly has a role in reviewing the urgency-related diagnostic groupings that work in emergency departments and other areas of clinical practice. So I'm going to move on and talk a little bit more detail about some of these areas, and I'll start in the area of teaching and training and touch on research. This was presented in some detail yesterday in, I think, one of the concurrent sessions, and not everybody perhaps had the full opportunity to hear the direction things are taking. But I'm not going to repeat much of what was said yesterday, but instead perhaps talk about some of the difficulties, particularly in the area of the embedded training. To create a classification framework in teaching and training obviously is a fairly significant task, and over that creation we need to look at the various different trainee types, not just the allied health, nursing, medical trainees, but also their different tiers of training, in that the undergraduate level, the postgraduate level, etc., all have unique and different aspects to the way in which they need to be undertaken, and as a result of that, we have to dig down and look at the actions. Obviously, in a lot of undergraduate training, the direct type teaching is fairly significant, but as we get into fellowship training, for instance, in medicine, which I'm perhaps most familiar with, the embedded component makes a real difference to the way in which we undertake things. So I think it's easy to see how we can count and effectively price time spent in direct teaching, or how we can count and price the infrastructure that sits behind the teaching process. But it is quite difficult at times to determine what the embedded component is and how that impacts on clinical practice. I give the example, I suppose, again in my sort of field where it touches my practice. We train interventional cardiologists in my hospital, and I'm always, I hope there are not too many cardiologists in the room, I'm always sort of concerned that in fact I have these reasonably highly paid registrars in my department who it's difficult to see where they actually contribute to the overall outcome of the organisation, because it's a complex field, and they're really looking for time in the cath lab with their cardiology colleagues assisting them. So almost always they're doubled up with a senior cardiologist, and not only are they doubled up with a senior cardiologist, but they're probably reducing the productivity of the lab because they're proceeding much more slowly through the interventional process than would necessarily occur if the cardiologist was there just doing the procedure themselves. And again, that's not a static process in that your very first angioplasty, no doubt, is a relatively long process, but 3 years later, as you're leaving advanced training and about to qualify as a cardiologist, you're obviously far slicker at doing that same procedure. And so it's not a static process, and over that time there isn't a standard amount of delay that occurs because of embedded training. In surgery, I know that some of our surgeons are now doing non-teaching lists, effectively what they call rapid lists, where they actually book a lot more cases into a half day or a day list, because they deliberately don't teach in that list in order to increase the productivity and help with getting through the waiting list. So you can see that there is recognition that that embedded training in procedural specialties particularly impacts significantly. But it's not just the procedural area. We adjust our clinic templates in cognitive physician practice in order to accommodate training at the same time, whereas I might see 30-minute new cases and 15-minute reviews in my clinic. If I've got a registrar that I'm supervising who's running a parallel clinic, I increase the time so that I've got time to review the cases with the registrar at the same time. So, although overall we perhaps see more patients than I'd see alone, it's not effectively a doubling, and it does slow down the number of patients I directly see. Or we look at models in outpatients, what is described as a helicopter model, where in fact you might have a series of clinicians in a clinic who are all at a trainee level and are being supervised by a single specialist who doesn't actually have a list of their own. All they're doing is dodging in and out and oversighting their juniors in that model. From a research perspective, obviously the capacity of the organisation to undertake research is the key part of the discussion, as opposed to actually funding direct research. Moving on, and the theme of the conference has very much been in the field of pricing for quality and safety, and I don't think there's any doubt that all of us want to find a mechanism that incentivises the quality care, and whether one does that with rewards or whether one does that with more punitive impacts, it's clearly going to need to be a balance, because we need to find a way that allows that allows reform to occur, allows hospitals and providers to improve their quality whilst over time, and allows even those high-performing organisations to be incentivised for further improvement and to retain that high performance. So the joint working party between the Commission and the IHPA was established, and again this was touched on yesterday, so I won't go into significant detail. But I'll also note that, and I believe it's going to be discussed later today, the ABF benchmarking portal is also under development, and that is no doubt another product that is going to assist in maintaining high standards and quality in the clinical community. But to follow on from what Mark Cormack said yesterday with regard to the initial intent to look at things like not paying for sentinel events and to look at reduced remuneration, etc., for where avoidable complications occur. What is required and what is now reasonably well developed are a series of hospital-acquired complications that have been agreed on by leading clinicians in the working group, and that is 40, and we've been through those yesterday. There needs to be a set of quality standards that sit around that. There needs to be an opportunity to have guideline-based care established around those processes, and so the Commission's guidelines and clinical standards, such as the orthogeriatric model of hip care that has recently been published, provides a framework and a recipe, so to speak, for making sure that that quality is able to be maintained. But the process of linking that price and quality equation in a way that doesn't have unintended consequences is, I think, is still difficult, and I think that it's going to be challenging, as will the implementation, because obviously what we don't want is to create an environment where organisations are shy when it comes to taking on patients that might be of higher risk. We need the high-risk multi-morbid patients to still have the same access to procedures and healthcare. We don't want a situation where we start modifying our access to those patients so that because of a risk of reduced remuneration, because they are intrinsically at higher risk of the potential complications that might have an outcome of that nature. So we do need to protect that process and move forward in a way that incentivises improved care and is not too punitive that it deters patients getting access to good quality care. I'm going to talk a bit about what I've described as horizon scanning. One of the things that the Clinical Advisory Group does at its regular meetings is potentially go through a list of things that the Independent Hospital Pricing Authority is looking at from the point of view of whether they need to be considered for pricing. And that may be processes within organisations. It may be new procedures. There may be new devices that are coming on the market that that obviously have cost and that may or may not be of a volume that's going to impact on price in the long run. And so we work our way through quite an exhaustive spreadsheet, usually in very small writing, that we attempt to establish which ones of those are worthy of further work by IHPA and which ones aren't. And I mean there are good examples of that. We've looked at a number of cardiac devices. We've looked at some endovascular stuff. We've looked at particular new drugs that are sometimes going to change the way in which care is delivered. But there are good examples that we haven't looked at yet. And I was struck the other day. I was at another meeting, and one of the speakers was talking about the use of a particular drug to replace a clinical procedure. The clinical procedure he was talking about was the correction of Dupuytren's contracture. Now, Dupuytren's are little contractions that occur on the palms of your hands and result in your fingers becoming fixed and flexed. And it's quite a complex, despite it sounding simple, procedure to release those fingers. So much so that quite a lot of people opt to have the finger amputated because it tends to recur, and having a permanently flexed finger, although it has some advantages, is not necessarily what people want to do, particularly when they're involved in manual tasks. So there is now a collagenase enzyme that you can actually inject into that fibrous contraction, which effectively dissolves the contracture over a period of time, and then by sort of passive remobilisation you can get the finger mobile again. That can be done under local anaesthetic, or it could be done under a general anaesthetic with a more vigorous manipulation, but it's clearly changing quite significantly, or has the potential to change quite significantly the direction we take in the care of those sort of patients. So that's the sort of thing that might come to us for consideration in horizon scanning. Moving on to some of the unintended consequences, and I see this in my own organisation. I now have doctors who are becoming data addicts. The fact that this data is now available, because we report it, this data is now available to the clinicians in the organisation. They've become quite addicted in my organisation to that data, and as a result of that, we've actually been able to undertake quite a degree of clinical reform as a result of the fact that we now are able to count and identify the direction in which things are moving in our organisation from a model of care perspective. It's not just necessarily about the money and the finance, it's about the activity, and it's about finding the efficiencies and having the opportunity to benchmark those efficiencies across larger groups of organisations. I think, as a result of that, there's been some flow-on effects into other areas of clinical practice. I think that the Choosing Wisely campaign, or the Evolve, as the College of Physicians are calling it, where we're looking at particular procedures across our spectrum of clinical practice that perhaps are not any longer based in good scientific or efficient patient care, and trying to reduce and remove some of those things, is actually a product of having this better data. So there are and I don't think there's any doubt that the issue of clinical integration and how we are challenged to fund a more integrated practice across the spectrum of clinical environments, both inpatient and outpatient environments, and specialty practice provided in the ambulatory environment, and so I think that the opportunity for the clinical advisory group and for IHPA to work into that space of the area of bundling care, bundling prices, and making sure that we're striving effectively for appropriate clinical integration in a cross-sectoral way. And I think what else is next? I think to putting the patient a bit more in the centre of some of these things, trying to take a patient-centric view of how clinical integration looks around us is probably worthwhile. Now, as a sort of cathartic exercise, I'm going to, given that we've talked about complications, and I'm going to present just briefly a case which had a fairly significant complication and almost was a catastrophe. This is, amongst my clinical practice, I look after a stroke unit, and some time ago a gentleman presented to our organisation, a man in his late 60s. He presented about 2 hours after the onset of stroke. He was densely hemiplegic, and for those who are not stroke physicians, he effectively had no function in his right arm, just a little bit of movement in his right leg. He was unable to communicate effectively or speak effectively. He understood some 1 and 2 stage commands, but really he was struggling. Clinically, it would appear that he'd had a left middle cerebral artery embolus and cerebrovascular accident as a result of that. So, because he was punctual in his arrival, we had an opportunity to try and intervene in this otherwise previously well man who was still in the workforce and married, and although his children were adult children, he was well supported. So what do? We do a scan, and the scan was basically normal, which is encouraging. Means that there's a real chance that that there's some salvageable brain there. There are a series of more complex scans we do nowadays that will give us a little bit more information. But essentially, what we're looking for there is to make sure there's no blood, because we're going to proceed and thrombolyse this gentleman, and that's exactly what we did. We gave him TPA through the vein, and within about 45 minutes, he got full resolution of his stroke. He suddenly could use his arm again. He could speak again. He was back to normal. So. As this occurs with thrombolysis, somewhere between 30 and 40% of cases. So, we gave ourselves a good pat on the back and thought this was a very wise decision, and we were impressed with our own performance, and set off to celebrate over a well-earned cup of coffee. But 45 minutes later, I was called back to see the patient urgently. He now had almost no blood pressure. His neurology was still intact, so he's still recovered from his stroke, but he was shocked, and he had a massive revealed GI bleed, and so we had a lot of blood coming from the bowels, and we resuscitated him with difficulty because the gentleman who's got no capacity to clot, in fact, is circulating a drug that stops you clotting, isn't easy to resuscitate in those circumstances. But we did successfully resuscitate him, and once he was stable a day or so later, we had a look in the upper and lower gut to see what we could find. And what we found in his large bowel, in the cecum, which is there on the right-hand side of the patient and a long way from the end of the bowel, was a cancer. It was quite a small cancer, but it was undiagnosed and unlikely to be diagnosed. Cecal cancers often go without diagnosis because they are so proximal in the bowel that they're relatively asymptomatic, and they're often diagnosed after they've metastasised, and after a treatment for cure is almost impossible. So he had a cecal bowel cancer. He had a hemicolectomy 6 weeks later and was cured. Not a fairly significant complication, but obviously not all complications end badly. And although I'm not advocating thrombolysis as a screening tool for bowel cancer, I think we do need to sometimes recognise that complications are complex. Thank you. Dan.
Please also say who you are and where you're from.
Thank you. Jane Hall, I'm an authority member, and I'm an economist, so I don't know anything about the clinical stuff except as an occasional participant observer. But I was struck by what you were saying about the teaching and training and the embedded nature of it, because to me it's sounding like there's a static efficiency and there's a dynamic efficiency. And part of what we have to have for a sustainable health system is the capacity for it to be flexible and agile and change. So that's what I'm hearing and translating into my language. And I wondered if you could just talk a bit more about that, not just in the teaching and training issue, but in terms of running the hospital. Can we make it so efficient that it doesn't have the capacity to change? And is that something we should be wary of?
I think I think there is a, as we train, and I'll start in the sort of training area. I think as we train, we have a clear obligation to make our hospitals, be they public, private, or otherwise, environments where we are thinking about succession planning and where we're thinking about training the workforce for the future. So I do think that that the drive to clear waiting lists at all costs does put at risk at times the capacity to embed training. And I think the very fact that we're having this conversation and that there's a working group looking at teaching, training and research is an acknowledgement that it needs to be embedded in the business as usual of the vast majority of hospitals. And so as soon as you recognise that efficiency of training is also a product of your health system, and stack that up as a KPI beside waiting list clearances, NEAT targets, NEST targets, etc., then you are simply creating an environment where you're able to do all of those things in parallel, as long as they are given equal priority by hospital administrations. And as I say, I think the importance of this piece of work is that it recognises that this needs to be embedded in the business as usual of an organisation.
One more question, if anyone has one. Perhaps very quickly, what I'll just ask Alasdair is that maybe the question on notice almost, the future of IHPA with bundling, safety and quality pricing. Are there any resources or requirements that you think the CAC will have in the future that you don't have at your disposal now, given the agenda going forward? Probably a difficult question, but...
I think the CAC is well resourced. I think there's recently been some transition and changeover in it, and we probably need to make sure that we're broadening the multidisciplinary nature of it a little. In that we've had some resignations in that area due to transitions in practice, but also I think as we become aware that that acute care isn't simply the preserve of acute hospitals, and as we become aware of mixed models, hospital avoidance, etc., perhaps the time will come when we perhaps need some more resources from that sector in the CAC to give that perspective. And then there's the question of how you effectively integrate healthcare consumers into that environment as well in a way that is productive.